Right, so a very good afternoon, everyone. So in this session, I will be discussing the disorders related to the pituitary gland. And right, so that particular disorder which I'll be discussing related to the disorders of the pituitary is the prolactinoma. Right. So first of all, let me just give you the anatomical classification of the pituitary gland, and I will discuss what are the hormones which are being produced from the pituitary gland. So first of all, that is if you take the pituitary gland, we have the two anatomical structures of the pituitary gland, and that includes the anterior and as well as the posterior pituitary. Right, that includes anterior and as well as the posterior pituitary. All right, now if you see the anterior pituitary, it will produce a list of hormones. Now what are the hormones produced by the anterior pituitary? That includes growth hormone, then we have adrenocorticotrophic hormone, next we have prolactin, then followed by that FSH, that is follicle stimulating hormone, then we have luteinizing hormone, TSH, thyroid stimulating hormone, and as well as the endorphins. So these are the hormones which are being produced by the anterior pituitary. Now you take the posterior pituitary. Posterior pituitary, it does not synthesize any hormones. Posterior pituitary will only act as the storage organ. And what are the hormones which are being stored within the posterior pituitary? That includes vasopressin. Right, this vasopressin, it is also called antidiuretic hormone, and the other important hormone is oxytocin. Right, the other important hormone is oxytocin. So these are the two important hormones which are being stored in the posterior pituitary, and depending upon the requirement they are being released. Right, depending upon the requirement they are being released. Okay, right, so that is about the hormones from the pituitary gland. Now the point that I wanted to tell you is about the prolactin. Right, so we will be discussing the disorders related to the prolactin now. So before going into the disorders associated with the prolactin, let me tell you how the prolactin secretion is being regulated. So if you take the prolactin secretion, it is regulated by dopamine. Right, it is regulated by the dopamine, and this particular dopamine, it is from hypothalamus. So now what the dopamine does, remember dopamine, if it acts on anterior pituitary, right, I'll repeat the point, dopamine, if it acts on anterior pituitary, dopamine will inhibit the prolactin secretion. Right, dopamine will inhibit the prolactin secretion, whereas if dopamine does not act, right, if dopamine does not act on the hypothalamus, right, if dopamine does not act on anterior pituitary, I'm sorry, if dopamine does not act on anterior pituitary, then the prolactin is released, right? Then the prolactin is released. Okay. If dopamine acts on anterior pituitary, then there will be inhibition of the prolactin secretion. If dopamine does not act on anterior pituitary, then there will be prolactin secretion which will be present within the individual. Okay. So that is about your the prolactin secretion. That is about the prolactin secretion. Now you take this clinical scenario here. Right. So you see this patient. We have a 35-year-old female presenting with 1 year history of menstrual irregularity, and there is also galacturia. She also has on and off headache, right? She also has on and off headache, and her examination reveals bitemporal superior quadrantanopia, right? Her examination reveals bitemporal superior quadrantanopia. And fundus examination showed primary optic atrophy, right? Fundus examination showed primary optic atrophy. Which of the following is most likely diagnosis in this case? Craniopharyngioma, pituitary macroadenoma, ophthalmic artery aneurysm, chiasmal glioma. Right. So what do you think will be the clinical diagnosis in this patient? Right. Yes. What will be the clinical diagnosis in this patient? Right. So the clinical diagnosis in this patient is right. So the clinical diagnosis in this clinical scenario is pituitary macroadenoma. Right. It is your pituitary macroadenoma. Okay. Now, first, let me start the discussion on this particular topic of hyperprolactinemia and as well as the prolactinoma. The pituitary macroadenoma, whatever is there in this patient, it is nothing but the prolactinoma. Right, the pituitary macroadenoma, whatever is there in this patient, is nothing but the prolactinoma. Now, if you take this prolactinoma, it is a clinical condition which is characterized by increase in the prolactin secretion. Right. Now you see one more question related to your pituitary gland. Which of the following is the most common type of the pituitary adenoma? Right. Which of the following is the most common type of pituitary adenoma? Thyrotropinoma, gonadotropinoma, prolactinoma, corticotropinoma. So in this question, the answer is the prolactinoma. Right? The most common type of pituitary adenoma is the prolactinoma. But if the option is in other way around, I'll tell you. The most common tumor of the pituitary is non-secretory adenoma. Right? Non-secretory adenoma, that is the most common tumor of the pituitary gland. All right. But if the question is asked, what is the most common secretory tumor of the pituitary gland? Right? What is the most common secretory tumor of the pituitary gland? Then the answer will be prolactinoma. Okay, so these are the two important questions where most of the students will get confused. And please remember this, most common tumor of the pituitary is non-secretory adenoma, whereas most common secretory tumor of the pituitary, it is your prolactinoma, right? Now let me take up the discussion related to your prolactin, right? Yes, so the answer in this question is your prolactinoma. Now you take the basic physiology of the prolactin first, right? So what I will discuss first, I will discuss the basic physiology of the prolactin. Then I will move on to the conditions of hyperprolactinemia and as well as prolactinoma. So prolactin, what is the physiological action in males and as well as females? If you take the physiological action in females, the physiological action of the prolactin in females is it will cause lactation by acting on mammary gland, right? That is one important thing. And the other important action of the prolactin in females is it will inhibit the ovulation, right? It will inhibit the ovulation. So these are the two important actions of the prolactin in females. Whereas you take the action of the prolactin in males. The action of prolactin in males, number one, it will inhibit the testosterone production, right? And it will inhibit the spermatogenesis. Okay, so basically what the prolactin does is, if the prolactin is produced in excess quantities, this prolactin will inhibit the action of FSH and as well as LH. Right? When the prolactin is produced in increased quantities, it will inhibit the action of the follicle stimulating hormone and as well as the luteinizing hormone. That is what is the physiological action of the prolactin. Now what happens in case of the prolactinoma? Right? What happens in case of the prolactinoma? In case of prolactinoma, it is a tumor which is originating from, right? It is a tumor which is originating from lactotroph type of cells. Right? Lactotroph type of cells of the pituitary gland. Okay, that is what is called as the prolactinoma. Now this prolactinoma, depending upon the size, right? This prolactinoma, depending upon the size, we have what is called microadenoma and macroadenoma. Right? We have what is called microadenoma and as well as the macroadenoma. Now, what do you mean by this word microadenoma? Microadenoma means the size of the tumor is less than 10 mm. Right? And macroadenoma means the size of the tumor is more than 10 mm. Okay, so microadenoma means the size of the tumor is less than 10 mm. Macroadenoma means the size of the tumor is more than 10 mm. That is what is the difference between the microadenoma and as well as macroadenoma. Now, you take another important points related. So, to just shortly summarize, prolactin is secreted from the posterior pituitary. Sorry, I'm very sorry. Prolactin is synthesized in the anterior pituitary. I'm very sorry. So prolactin is synthesized in the anterior pituitary and it is released from the anterior pituitary. And the secretion of the prolactin is completely under the control of dopamine. Now, what this particular dopamine will do is, dopamine is the one which will inhibit the prolactin production. But if dopamine does not act on anterior pituitary, then the prolactin is being produced. Now, prolactin in females, if it is being produced in excess quantity, it will cause lactation and it will also inhibit the ovulation. Whereas the prolactin in case of males, if it is being produced in excess quantity, it will inhibit the testosterone and as well as it will also inhibit the spermatogenesis. And the next important thing is this particular prolactin, we have a tumor called from the pituitary, that is prolactinoma. And this particular prolactinoma, depending upon the size, we have microadenoma and macroadenoma. Microadenoma is that where the size of the tumor is less than 10 mm, and macroadenoma is that like where the size of the tumor is more than 10 mm. Okay, so this is what is your the microadenoma and as well as the macroadenoma. Now, followed by that, yes. Now, you should know what are the causes of the hyperprolactinemia, right? You should know what are the causes of hyperprolactinemia. All are the causes of hyperprolactinemia except options are bromocriptin, phenothiazine, methyl dopa, metoclopramide. Yes. So can anyone make an attempt like which among the following will not cause hyperprolactinemia? Right. So the answer to this question is, right, the answer to the question is the bromocriptin. The answer to this question is bromocriptin. Okay. Just 1 second. Correct. Right. So all are the causes of hyperprolactinemia except. So what is the answer here? It is the bromocriptin. Now, let me tell you why the answer is the bromocriptin. Okay. Bromocriptin, in fact, it is used in the treatment of hyperprolactinemia. Right? In the treatment of hyperprolactinemia. Right? In the treatment of hyperprolactinemia, we use this particular bromocriptin. Now, let me now tell you what are all the various causes of the hyperprolactinemia. Right? Let me tell you what are all the various causes of hyperprolactinemia. Right. So if you take the etiologies causing hyperprolactinemia, right. So the etiologies causing the hyperprolactinemia, it includes the systemic causes. Now, what are the systemic causes of hyperprolactinemia? The systemic causes of the hyperprolactinemia, it includes hypothyroidism, right? It includes hypothyroidism and as well as chronic renal failure, right? Hypothyroidism and as well as the chronic renal failure. Now, in case of hypothyroidism, what will happen? Right? In case of the hypothyroidism, what exactly will happen? Okay. So what exactly will happen in case of the hypothyroidism is that in patients with hypothyroidism, there will be increase in the TRH, thyroid releasing hormone, that is in primary hypothyroidism, right? Why? Because in primary hypothyroidism, the TSH and TRH both are increased in order to increase the thyroid hormone secretion. Now, this TRH which is increased from the hypothalamus, remember, it will stimulate the prolactin production from anterior pituitary. Right, it will stimulate the prolactin production from the anterior pituitary. Okay, right, that's a very important point. So in that way, it will cause the hyperprolactinemia. Right, in that way, it will cause the hyperprolactinemia. Right, next. right? So now you take in case of the chronic renal failure. Now what happens in case of the chronic renal failure is that is, in case of chronic renal failure, there will be increase in the prolactin levels. Now the question is why? Why? Because in patients with the chronic renal failure, the prolactin, it doesn't get excreted out. The prolactin has to be metabolized and gets excreted through the kidney, right? The prolactin, it has to be metabolized and excreted through the kidney. So whenever there is chronic renal failure, the prolactin is not excreted out. So that will lead to the hyperprolactinemia. That will lead to the hyperprolactinemia, right? Next, then followed by that, right? Now you should know what are the drugs which will cause the hyperprolactinemia, right? You should know what are the drugs which will cause the hyperprolactinemia. Now the drugs causing hyperprolactinemia is, one is your metoclopramide, right? Next, it is your phenothiazine, then methyl-dopa and metoclopramide. But bromocriptine will not cause hyperprolactinemia. In fact, bromocriptine is given in the treatment of the hyperprolactinemia. So please remember that very, very important point, right? So drugs causing include metoclopramide, phenothiazine, and we have an atypical antipsychotic, that is risperidone, right? That is risperidone. Even risperidone can also cause this particular hyperprolactinemia. Okay, so please remember that very, very important point. Next, followed by that, yes. Now there are certain physiological causes for hyperprolactinemia. Now what are the physiological causes for hyperprolactinemia? The physiological causes for hyperprolactinemia are pregnancy, lactation, chest wall stimulation, sleep, and as well as stress. So these are the physiological causes for hyperprolactinemia, right? These are the physiological causes for hyperprolactinemia. And pathological conditions, just now I have said you, chronic renal failure and hypothyroidism. And drugs, right? What are those drugs? These particular drugs include phenothiazines, risperidone, metoclopramide, methyl-dopa. These are the drugs which will increase the prolactin levels. And the other thing is cimetidine. The other thing is cimetidine. Okay, so these are the drugs which will increase the prolactin levels. Next, followed by that, yes. Now you see a clinical scenario here. We have a 30-year-old woman presented with secondary amenorrhea for 3 years along with galacturia, right? So a 30-year-old woman presented with secondary amenorrhea for 3 years long along with galacturia. Now the most likely cause of her symptoms would be, so what do you think is the answer here? The options are craniopharyngioma, prolactinoma, meningioma, subarachnoid hemorrhage. So the answer in this particular question is prolactinoma, right? The answer in this question is the prolactinoma. Okay, now why the answer is prolactinoma, right? Why the answer is prolactinoma, right? Let me discuss that. So I have taught you already, that is the prolactinomas, it exists in the two scenarios. One is microadenoma and the other one is macroadenoma, right? So let me teach you that microadenoma and as well as macroadenoma in detail now. Okay, so prolactinoma, you have microadenoma and as well as the macroadenoma. Now what did I tell you? Microadenoma means the size is less than 10 mm. Macroadenoma means the size is more than 10 mm. Microadenoma less than 10 mm, macroadenoma more than 10 mm. Now you take in case of microadenoma, right? You take in case of the microadenoma. In case of microadenoma, so please remember this very important point. These individuals, they will have only endocrine manifestations. Right? These individuals, they will have only endocrine manifestations. Whereas you take in case of the macroadenoma. In macroadenoma, what is that they will have? In case of macroadenoma means what? The size of the tumor is more than 10 mm. In this, they will have endocrine manifestation, and they also have the mass effect. Right? They will have endocrine manifestation, and they will also have what is called mass effect. Now, what do you understand by the word mass effect? Now, when the pituitary is growing in size, right? When the pituitary is increasing in its size, this tumor or this pituitary will compress the surrounding structures. Right? This pituitary will compress the surrounding structures, and that is what is called as mass effect. Now, the point is, where is your pituitary gland located? The pituitary gland, it is located within the sella turcica. Right? The pituitary gland, it is located within the sella turcica. Now, the pituitary gland, which is located in the sella turcica, whenever it is growing in size, right? Whenever it is growing in size, this can cause the compression of the surrounding structures. Right? Now, what are those surrounding structures? Right? Now, accordingly, I will show you, and then I will teach you the clinical manifestations accordingly. Okay? So, right. So, you see this? This is the pituitary gland, right? And this is your sella turcica. Right? This is your sella turcica, in which you have the location of the pituitary gland. In which you have the location of the pituitary gland. Now, when the pituitary gland, when it is increasing in size, right? When the pituitary gland, when it is increasing in size, it can cause the compression of the surrounding structures. That is what I have taught you. Now, what are those surrounding structures? Right. So these are the surrounding structures. Right? These are the surrounding structures. Now, what are those? Number one, exactly above your pituitary gland, this is your optic chiasma. Right? This is your optic chiasma. So what is optic chiasma? Optic chiasma, it is nothing but the crossing of the optic nerves. Right? The crossing of the optic nerves. That is what is called as the optic chiasma. Okay. And the other important structures you can observe here, this is your internal carotid arteries. These are your internal carotid arteries. Okay. The branches are here. Okay. Yeah. This is your internal carotid artery. Right. And the other important structure surrounding the pituitary gland is the cavernous sinus. Okay. You see this? This is your cavernous sinus. Right. This entire area is the cavernous sinus, which is present on either side of the sella turcica. You have both on right side and as well as the left side. And exactly below that, you have the sphenoid sinuses. You see this? These are your sphenoid sinuses. Okay. So now whenever there is macroadenoma, right, when the size of the pituitary is large, right, when the size of the pituitary gland is very large, then in such case, please remember that the pituitary gland, whenever it is increasing in size, it will cause the compression of the optic chiasma. Right? It will cause the compression of this optic chiasma. So whenever there is compression of this optic chiasma, the individual will have the visual manifestations. Visual impairment will be there. And that particular visual impairment will be in the form of bitemporal hemianopia. Right? This visual impairment will be in the form of bitemporal hemianopia. So that is the visual impairment like you'll have because of the compression of the optic chiasma. Okay, so that's a very important point. Please remember that. Compression of the optic chiasma will lead to what is called bitemporal hemianopia. Now, accordingly, right. So accordingly, you take in case of microadenoma and as well as macroadenoma, what will be the manifestations? So you take in case of microadenoma. I said you already, you will have only endocrine manifestations. Now these endocrine manifestations, they are different in males and as well as females. Right? These endocrine manifestations, these are different in males and females. So in the beginning, the physiology aspect I have taught you. So what is the physiology aspect I have taught you? That in case of males, whenever there is increase in the prolactin levels, there will be inhibition of the testosterone production and there will be inhibition of the spermatogenesis. So accordingly, in case of the prolactinoma, in males, right, in males, you will have loss of libido, right? You will have loss of libido. And why is this particular loss of libido? That is because of the inhibition of the testosterone production. That is one thing. And apart from the loss of libido, these individuals, they will also have infertility, right? So why do they have this infertility? They will have infertility in case of prolactinoma in males because there is no spermatogenesis. Next, followed by that, you take in case of the females, right? You take in case of the females. So in females, in case of prolactinoma, what are the manifestations you will have is, number one, the ovulation is not occurring. So when the ovulation is not occurring, these individuals will have amenorrhea. Right? These individuals, they'll have amenorrhea. Okay. And in these individuals, females also, there will be infertility. Why? Because there is no ovulation at all. So these are the endocrine manifestations in case of prolactinoma. Right? Endocrine manifestations in case of prolactinoma. And endocrine manifestations are seen in case of microadenomas. Whereas, what did I teach you related to macroadenoma? In case of macroadenoma, right, in case of macroadenoma, what is that you will have is, you will have endocrine manifestations and you will have the mass effect. Right, endocrine manifestations and as well as the mass effect. Now, what is that particular mass effect? Right, what is that particular mass effect? Mass effect is that, so when do we call macroadenoma? When the size of the tumor is more than 10 mm. Right, when the size of the tumor is more than 10 mm, then we use this word called macroadenoma. Now, the mass effect is that these patients, when the size of the tumor is increasing, it will go and compress the surrounding structures, that is optic chiasma, and that will lead to visual impairment. Right, that will lead to visual impairment. And the visual impairment that you will see is bitemporal hemianopia. Right, the visual impairment you will have is bitemporal hemianopia. So there will be loss of vision in both the eyes. Right, there will be loss of vision in both the eyes in the lateral half. Okay. Right, so these are the so both the eyes, lateral half, the visual field is lost. In both the eyes, the lateral half, the visual field is being lost. That is what is called as bitemporal hemianopia that you will see in patients with the macroadenomas of the prolactinomas. But if the question is asked Like, which is more common? Is it microadenoma more common or macroadenoma more common? Remember, it is microadenomas which are more common than compared to that of macroadenomas. Right? Microadenomas are more common than compared to that of macroadenomas. Right? Next. Now, followed by that, now let me tell you how to investigate how to investigate a case of the prolactinoma. Right? So if you see a question here, investigation of choice of hyperprolactinemia is thyroid releasing hormone stimulation estimation, luteinizing hormone estimation, the prolactin estimation, estradiol estimation. Right? So the answer to this question is the prolactin estimation. The answer to this question is the prolactin estimation. Now you need to know how much is the normal prolactin levels. Right? You need to know how much is the normal prolactin levels. So if you take the normal prolactin levels, that is around 5 to 20 nanograms per ml. Right? The normal prolactin levels are 5 to 20 nanograms per ml. That is a normal prolactin levels. All right. Now, in case of prolactinoma, right, in case of prolactinoma, the prolactin levels will be more than, right, the prolactin levels will be more than 200 nanograms per ml. Right, the prolactin levels will be more than 200 nanograms per ml. Okay, that is what you will see in case of the prolactinoma. Whereas if the prolactin levels, if they are in a range of 100 to 200 nanograms per ml, this will strongly suggest prolactinoma. Right, this will strongly suggest the prolactinoma. And if the prolactin levels are less than 100 nanograms per ml, this might be due to any cause except prolactin secreting adenoma. Right, except prolactin secreting adenoma. Now I have said you some of the causes of hyperprolactinemia. What were some of the causes of hyperprolactinemia? Like chronic renal failure, hypothyroidism, drugs like phenothiazine, risperidone. Then we had this cimetidine. So these are some of the metoclopramide. These are the drugs which will increase the prolactin levels. So if it is less than 100 nanograms per ml, it is definitely not a prolactinoma, but there is hyperprolactinemia due to some other condition. Right? It is hyperprolactinemia due to some other condition. Okay. So this is about the estimation of the prolactin levels. So estimation of the prolactin levels is the investigation of choice. Now, for suppose, right, for suppose, if the level of the prolactin, if it is more than 200 nanograms per ml, you need to suspect the prolactinoma. Right? You need to suspect the prolactinoma. Now, whenever you are suspecting prolactinoma, what is the next line of investigation? That is MRI. Right? If the levels are more than 200 nanograms per ml, what is the next line of investigation? That is MRI of the brain. MRI of the brain will diagnose what it will diagnose. It will diagnose if it is like whether it is microadenoma or macroadenoma. Right? It will diagnose whether it is microadenoma or macroadenoma. That is the importance of your doing the MRI. That is the importance of doing the MRI. Okay. Now, then followed by the investigations. Right. Now you need to know how to treat these patients with the prolactinoma. Coming to the treatment. So you see this particular clinical scenario here. We have a young woman with secondary amenorrhea and galacturia. Right? We have a young woman with secondary amenorrhea and galacturia. And MRI shows the tumor of less than 10 mm diameter in the pituitary fossa. Now, what is the treatment that you need to give in this patient? Hormonal therapy for withdrawal bleeding, radiotherapy, chemotherapy, bromocriptine, surgery. So the size of the tumor is less than 10 mm. So when the size of the tumor is less than 10 mm, what does that tells you? That tells you that the individual is having microadenoma. So how do you approach this particular patient? Or how do you treat these patients? Right. So anyone want to make an attempt of this question? So answer to this question is bromocriptine. Right? Answer to this question is bromocriptine. So bromocriptine is a treatment that you need to give in case of microadenoma. Now let me tell you how to approach a case of prolactinoma. Now, whether it is microadenoma or whether it is macroadenoma, right? Either microadenoma or macroadenoma, the treatment of choice that you have to start with is the bromocriptine, right? So let me tell you how to approach a case of the prolactinoma. Right. So based on the estimation of, right, now the individual is having the clinical features suggestive of hyperprolactinemia. What is the first thing you have to do? You have to check the prolactin levels, right? You have to check the prolactin levels. If there is prolactin levels elevated more than 200 nanograms per ml, then you need to do MRI of the brain. Now, what is the purpose of doing MRI of the brain? The purpose of doing the MRI of the brain is to rule out whether it is microadenoma or macroadenoma. Right? The purpose of doing MRI of the brain is to rule out whether it is microadenoma or macroadenoma. So microadenoma means the size of the tumor is less than 10 mm. Macroadenoma means the size of the tumor is more than 10 mm. Now, the next important thing is whether it is microadenoma or macroadenoma, right? Whether it is microadenoma or macroadenoma, whatever it is, the immediate line of management is dopamine agonist, right? The immediate line of management is dopamine agonist. Okay. Now, first we will take up how to approach a case of microadenoma. Then later on, I will tell you how to approach a case of the macroadenoma. Now, you see here. So, you take in case of microadenoma. What is that you are giving initially? Bromocriptine, right? Dopamine agonist you should give. What are the dopamine agonists that you are aware of? One is your bromocriptine, right? One is your bromocriptine and the other one is cabergoline, right? The other one is cabergoline. So these two are your dopamine agonist. Now, after giving this particular dopamine agonist, you need to monitor the serum prolactin levels, right? You need to monitor the serum prolactin levels. For suppose, if the serum prolactin levels are less than 20, then it is just a maintenance treatment. Continue the same treatment, right? Whatever the bromocriptine you are giving, you continue the same. But in spite of giving bromocriptine or in spite of giving cabergoline, if the levels are in between 20 to 50, then what you need to do, you need to reassess the diagnosis and increase the dosage of the bromocriptine or cabergoline, whatever you are giving. Whereas you are giving bromocriptine or the cabergoline, but the level of your prolactin levels are more than 50 micrograms per liter, right? Sorry, more than 50 nanograms per ml. In such case, giving bromocriptine or cabergoline will be of no use. That means the dosage, whatever you are giving, is not being sufficient. You need to consider for surgery, right? You need to consider for surgery, right? So now what is the surgery that you have to consider, right? What is the surgery you have to consider? So the surgery, what you have to do is, Transsphenoidal transsphenoidal microsurgical approach. Transsphenoidal microsurgical approach. So that is about the treatment of the microadenoma. That is when the prolactin levels are more than 50 in spite of giving this bromocriptine or cabergoline. Whereas you take in other way around. In case of macroadenoma, in macroadenoma also you start the treatment with bromocriptine or the cabergoline. We don't do surgery immediately. Even in case of the macroadenoma, we will start with the same bromocriptine or cabergoline, dopamine agonist. But what we will do here is we will repeat the MRI after 4 months. We will repeat the MRI within 4 months. Now within 4 months, within 4 months, if there is tumor shrinkage or if there is decrease in the dopamine levels, then you monitor the prolactin and continue same bromocriptine or cabergoline, whatever you are giving in case of macroadenoma. Whereas you have repeated the MRI after 4 months, you have repeated the MRI after 4 months, but there is no tumor shrinkage, and there is persistent hyperprolactinemia. That is the point when you need to consider for surgery. That is the point when you need to consider for the surgery. Okay, so that is about the treatment of the prolactinoma. So either you take microadenoma or you take macroadenoma. The treatment is same. You have to start with the dopamine agonist. But further approach completely depends upon how the patient is responding to your bromocriptine or cabergoline. Then followed by that, what are the indications for surgery in case of prolactinoma? So these are all the indications for surgery. Number one, dopamine resistance or intolerance. Dopamine resistance or intolerance. That is one indication for surgery in case of prolactinoma. You are giving dopamine agonist, but there is resistance or there is intolerance. Second, presence of invasive macroadenoma with compromised vision. Presence of invasive macroadenoma with compromised vision. Then that is also an absolute indication for surgery. So these two are the important indications for surgery in case of prolactinoma. And in case of microadenomas, 70% of cases, there will be normalization of the prolactin after resection. Whereas in 30% of cases with the macroadenoma, they become successful after the resection. So this is about the treatment of the prolactinoma. So this is in total about the topic of the prolactinoma. So prolactin is the hormone which is being synthesized in the anterior pituitary and it is being regulated by the dopamine. If dopamine levels are high, prolactin levels are low. If dopamine levels are less, the prolactin levels are high. And this physiological hyperprolactinemia is seen in case of lactation, pregnancy, sleep, chest wall stimulation. So these are the conditions where there will be physiological hyperprolactinemia. Pathological conditions, systemic conditions like hypothyroidism and chronic renal failure. And drugs like phenothiazine, risperidone, then metoclopramide, methyl-dopa, these are the drugs which will cause the hyperprolactinemia. Then the clinical manifestations completely depends upon whether it is microadenoma or macroadenoma. In microadenoma, only endocrine manifestations. In macroadenoma, both endocrine and as well as the mass effect. And investigation of choice, prolactin levels. And then followed by that MRI. And the drug of choice will be bromocriptine or cabergoline. And when there is dopamine resistance or intolerance, then you need to consider for surgery. And what is the surgery you will do? That is transsphenoidal surgical resection has to be done. Okay, so this finishes the topic of the prolactinoma. Right? Thank you very much.